All right, ladies and gentlemen, here we are again. I am Dr. Chris Nelson, based out of Redding, California, way up at the top of the state near Mount Shasta. So today I have a really cool case. It is a 4-unit implant bridge on top of 2 implants, the front 4 teeth. No pressure, right? So we got to meet this patient from Dr. Schaff and Dr. Liska at Team Perio. Dr. Schaff is a local orthodontist. He has a lot of experience, and he was working with Dr. Liska to set up this particular patient's case in anticipation that we were going to do 2 implants and a 4-unit implant bridge. So this is complicated stuff, and especially when the patient has a high lip line, the gums are on the thinner side, and there's just really nowhere to hide with the lip. A lot of times we can find relative success with a low lip line and very thick gums and older patients. Those kind of cases are pretty straightforward. But this patient is young and she has high aesthetic concerns. She actually works in dentistry and she wanted a slam dunk. So I was honored to get to meet the patient. She's super sweet. And it was a little bit scary to kind of work up the case, but also that scariness or excitement is more a passion to make sure we do a great job. So we were able to work up the case, and this video is part 1 of 2. So this is taking the patient from onboarding all the way to the custom temporary bridges the custom temporary bridge that we made for the patient. Okay, so this is part 1 of 2. So she came in, she was in braces. She had a very nice temporary bridge under the brackets, and they were all sitting on top of one individual tooth that was just not a very happy tooth. So it was doing a lot of work. And if the braces and wire were removed, that whole thing would be loose and because that tooth was not very happy. So we did our normal process. We did a very comprehensive workup, and we worked up 2 different scenarios for the patient. One was whether or not we were going to correct her dental and midline to match up with her skeletal midline. And the other one was a version where we didn't correct for her midline. So when we take portraits, we have the patient sit up very straight, and we actually will adjust the head on the picture and make sure their eyes are very straight. And then we can look at dental versus skeletal midline. And when we did our analysis, we actually noticed that, and she knew this already, that her dental and skeletal midline didn't match. And so we talked about, hey, what are your goals? Is that really the most important thing for you, or is it replacing the teeth? Because what we decided was, if we were going to correct that dental and skeletal midline, or correct the dental midline to match the skeletal midline, we actually had to do more than just the front 4 teeth. We were talking about doing work on the canines and possibly even one of the premolars. And why, you might ask? Well, we can actually fudge over everything a little bit more if we're taking away from that tooth and adding to this one, and taking away from that one and adding to this one. So after we went through our planning process and I asked a bunch of questions to our patient, we identified that her actual core values with this particular case was to get the front 4 teeth replaced, but also be conservative and not do a lot of dental work on the other teeth. So we pre-planned the case with our lab. We also worked with Dr. Schaff to finish the orthodontics. And then I worked with Dr. Liska at Team Perio to figure out where we were going to place the implants. And we kind of had all options on the table. We said, hey, do we want to place, well, we didn't say, do you want to place 4 implants? Because that would be kind of excessive. But we thought, do we place 3? Do we place 2? Are the 2 implants over here, or is there one here, or is it like this? And through pre-planning with Dr. Liska using a CT scan, so a 3D x-ray of the bone, and then also our 3D scans of the teeth and the photographs, all of that merged together, we came up with a surgical plan to place 2 implants in the best quality bone at the best angles that we could. So fast forward, orthodontics are done. The clearance and the bite is as ideal as possible. And then we went ahead and made a stay plate, which is a retainer that's removable, in advance of the surgery. So we had the braces finished, the temporary bridge, which was on one tooth, removed, the tooth removed, 2 implants placed, bone grafting sutures, I believe, and then the temporary removable partial, a stay plate to cover up the site while healing. And if you look at these pictures, you'll see the stay plate actually looked pretty good. Although if you look at a very high smile, you'll see the edge of the acrylic on top of the tooth. So that was the sort of thing that we were concerned about. This very high lip line, no place to hide, and how can we manage that? And you might ask, well, why did you do a stay plate instead of an immediate partial? In this case, with Dr. Liska's help, he determined that his surgical plan would be best suited with a removable appliance and not an immediate bridge, temporary bridge. So sometimes we'll do the immediate temporary bridge, but this one, he decided that it would be best with a stay plate. So the patient wore the stay plate, allowed healing for several months, and then we started doing our planning for the custom temporary bridge. Now you might ask, why don't you just do the final bridge? If you wore a stay plate, why don't you just do the final bridge? Well, you'll see here in a second, because we want to get everything sorted out so the patient's really happy. Look, at the end of the day, I really don't care what I do for the patient as long as they're happy in the end. That's my main goal. And a lot of times we do great with that. Sometimes we're off by a little bit, and then we use our really good communication to try to get from here to there and get to where everyone is happy and the work that we do is ideal. That work could just be a stay plate, or it could be a super fancy 4-unit implant bridge. So this case, we said, all right, we made the stay plate. That looked pretty good. We're going to use that as a guide and make some refinements and then do a custom temporary bridge. So again, we took a bunch of photos. We did a 3D scan of the implant locations, and then we worked with our lab, the Foresters in Shasta Lake, and they were able to go ahead and make a temporary implant bridge. And then we were able to deliver that. So what you'll see here is the implant bridge on the model. It looked pretty good, and you'll notice that there are access holes coming out the front of the teeth. Now that was a point where we, before I even got in the room, our patient was looking at the models because she's in dentistry, and she's like, I don't know if I want these holes coming out of the front of the bridge. Well, I actually showed her some pictures of another case, and there's a YouTube video about it on how we can hide access holes really, really well. So if you haven't seen that, go check it out. I'm not too afraid of having a facially positioned access hole, but I had a chat with her. I brought her in the back office here and showed her kind of some pictures. And I said, we can either hide the access holes with composite and using this technique in my other video, or we can actually try to have our lab do angled screw channels where the access holes are actually moved towards the lingual. There's some pros and cons related to that. And then the other option is we do the entire bridge cement retained. Well, having the patient be in dentistry, she kind of knows the pros and cons of all that. She understands those pretty well. And both of our preference is actually to do a screw retained bridge. The ideal situation is the screw retained bridge has the access holes behind the front teeth, so we're not having to plug them up. So we're going to talk with our lab about that. But either which way, we had the conversation about how it looked on the model, and we said, well, let's try it in. So we were able to try it in. You'll also see on the picture that one of the abutments is engaging and the other is non-engaging. So that's because the angulation of the implants is such that they both, one of them is going in with the shape so that it's preventing rotation, and the other one is just holding the appliance in. You don't need to really worry about that, but it's kind of interesting. I got a cool picture of it. So we had our custom temporary with an engaging and a non-engaging side screwed in place. And what you'll see is as we screw it in, because the healing cover screws are this big and the implant bridge abutments are this big, we had to allow the tissue to stretch. So what we do is we didn't do any anesthetic. We just tightened in the bridge and let it sit for like 5 minutes. And then we'd let the blanching in the tissue go down. And then I come back in the room and tighten each one, a couple more, half turns, quarter turns. And then we notice the blanching, check in with the patient. She's like, yeah, it's a little sore. And then we leave for 5 minutes, come back and adjust that. And so we're kind of like working our way up to where the bridge is seated all the way. So once it was seated all the way, I checked from the lingual to make sure that we had clearance so that the patient wasn't hitting the bridge when she was biting down. We also had her move her lower jaw around into excursions or slides to see if she was picking up any prematurity. We did notice that there was a little bit of a prematurity, so I addressed that with a disc. We actually disced the incisal edge of 8 and 9 to reduce that. And then we also noticed that it was very nice. Her canines were providing anterior guidance so that the bridge was separating and she was not hitting the implant bridge really at all, except for maybe a really extreme movement. So we were able to minimize the forces, and now she has a custom temporary bridge. Of course, it had screw access holes visible. So we used the technique that is explained in another video where we used a air abrasion technique with Siljet and some bonding agent, and then we used Omnichrome blocker from I've got another video of that too. So we used the blocker shade to cover up the access holes. We also used the standard shade of Omnichroma to just blend everything in, and then we were able to polish it and have it turn out really good. And then of course we took some portraits and made sure the head was nice and straight, and we took all of that information for our records so that we can evaluate it when the patient's not here. So what are the next steps? Well, in this case, we're going to have the patient wear this bridge for a period of a couple weeks to about a month. And I want to see what the gingiva does and what the papilla does in between the bridge. Now, the pontics, those are the fake teeth on the bridge, are ridge lap pontics. And what we've talked about from the beginning, we might want to do them as ovate pontics. Although I thought it looked really good. So we're going to see what the papilla does. If it grows in and fills in the space, we might just leave it. But there is some cool advantage to having the bridge look like it's coming straight out of the gums in an ovate pontic style. Like I said at the beginning, this case is super challenging. There's nowhere to hide with the smile and lip line. So that's the main reason why this is like, for sure, we had to do a custom temporary bridge and go through the time and the expense of doing that in order to get a great final result. And I think our final result, it remains to be seen, but it probably will be a screw retained 4-unit bridge on 2 implants. And I'm going to either hide the access holes out the facial or do an angled abutment screw channel and tighten them through the lingual. So we'll see. You'll have to come back and check it out. Anyways, I'm Chris Nelson, DDS, up in Redding, California. If you're up in the Redding area or greater Redding area and you want to get to know us, you can write a comment. I read all the comments. It's just fun for me. And if you want to be a patient, we're accepting new patients. It's best if you live relatively close, just because there's commuting. I talked to somebody from New York just a couple days ago, and he's like, I want to be your patient. And I said, there's a lot of really good dentists between New York and California. So I actually was able to help find him someone out there through some connections. So anyways, but yeah, I hope I made your day a little bit better. If you're a dentist out there looking at a case like this, work with a good lab, work with a good team, take photos. If you're a patient that can't come see us but are looking for something similar, again, make sure the dentist has a really good team around them, and taking photos and having the dentist be really proud of their work goes a long way for ensuring that you're going to get a good result. Because I'll tell you, when I'm looking at a case on my 55-inch computer monitor back there and blowing it up, high resolution, my standards are very, very high. And typically my standards are higher than the patient's standards, even when the patient standards are very high as well. So I hope you enjoyed the case. Thanks for listening. And we'll see you in the next video, part 2 of this one sometime in the future. Take care.